Thank you to the IT. And we can start. Good morning, everybody. I just want to start talking now about monitoring tools, MRI. So this is a good transition from echo. And I don't want to make it too complicated in this morning session now, talking about simple TGA, and I want to pinpoint some of the problems we discussed already yesterday several times. So muscle ascending RV dysfunction, buffer leak, stenosis, CCTGA, or other forms of complex post-operative states, RV dysfunction, arterial switch associated maybe with pulmonary stenosis, perfusion deficiency, probably is the better word, and also talk a little bit about aortic valve function, root dilation, and probably an issue which touches us all very much, coronary arteries. So I'm lucky to work with a technique which is pretty standardized, so inter-observer experience is not our problem. So I can lean back and drink a little bit of coffee. The machine is working in the background, and then we're having these images, and then I can go to the, well, it depends then I have to talk to, but let's say to the cath people and say, okay, look, there's no stenosis in the baffle. Here you can see pretty well the anatomy, visualize it, and the one or the other part of the baffle, and so the gross visualization is pretty easy. However, we have, of course, very strong limitations with the fine visualization of issues only echo can reveal. So our spatial resolution is by far not good enough to visualize a thin baffle leak. So there, in this case, we have to switch to a different technique, measuring flow. This is a method established about 10 years ago, and it became pretty much routine. And it's also pretty much straightforward. So what we are doing, we are measuring the flow at the level of the aorta. We are measuring the flow at the level of the pulmonary artery. We compare, and then we get an estimate about how significant a shunt might be across a baffle leak. The assessment of aortic valve dysfunction, we have learned that this is not too frequent, but it is a problem which can occur in the one or the other patient, works with the same technique. Again, a flow measurement method. So we have these visualization methods to see, well, there's a regurgitant flow, there's a regurgitant jet. We can also directly visualize the aortic valve. It works fine in most patients, not too fine in some. But this is not too helpful if we want to have and we are talking about monitoring, we are talking about follow-up in this session, if we want to get an estimate if the problem might grow to a significant problem, so that we have to consider reoperation and valve replacement. So basically what the method is doing, we are measuring the forward flow. These are the phases over time. This is the amount of flow at each time point. And this area under the curve gives you an idea about the amount of forward flow. This area under the area under this curve gives you an idea about the amount of regurgitant flow. But the literature shows pretty clearly the amount of regurgitant flow, the regurgitant fraction, is not related to outcome, is not related to progression of dysfunction, etc., etc. So there we have to talk about other parameters. So all these grading, basically, they are just an estimate, but they are not helpful for guiding therapy. So there do not exist, actually, guidelines based on MRI data, but on echo data. So when to reoperate a patient based on ventricular volumes, actually. So the anti-diastolic diameter is one of the most frequently used and established parameters, and it's said if it is crossing a limit of 50 millimeters by echo, then there's a grade 1 indication, smaller 45 to 50, grade 2. Always operate symptomatic patients, that says the guideline. So we made progress, though, coming guidelines based on MRI data, establishing that also for the aortic valve. We did that very fine, I think, in the past 5 years for the pulmonary valve insufficiency situation. So we have established reference values based on quantitative data for our age group. And these data now are plots from our well-known fellow patients, and these show then the deviation of the individual patient to to the reference data. So something like that is in work in progress also for the aortic valve. Then we can better decide where is the cutoff value when we have to reoperate so that we can prevent actually the progression of dysfunction into irreversible heart failure. And now the topic coronary arteries after switch. Yes, we can. Yes, we can definitely visualize the coronary arteries with MRI, much better with CT. These actually is a visualization of the coronary arteries after reimplantation after a kappa. Would be the same situation for switch. Yes, we can also visualize myocardial necrosis. So in an event of ischemic event, we can visualize necrotic tissue or tissue with, which have some edema. And yes, we can differentiate that also against other situations like, for example, inflammation processes. But what does it help? Yesterday, the question from Mr. Shakureshi was, there's a 20-year-old woman presenting to the physician after switch, and she wants to make sports. What are you doing? Okay, what can I do? I can visualize the coronary arteries. I can do that also and follow up. But we are not talking about somebody who has a classical ischemic problem with wall abnormalities and plaques and the risk of plaque rupture. We're talking about patients who are having some kinking maybe, probably. We do not know. We do not have any clue about the situation of the wall, what's going on in these patients. It never has been studied. So if there's a kinking, a slight kinking, let's assume maybe 25%. So asking back maybe to Peter, what shall we do with this patient? Placing a stent in a 21, so also our options after we made the diagnostics is not very reliable. The only way, the only issue I see these methods might be valuable is actually in the early state, if there's an early presenter, and we show, okay, there has been a ischemic situation, so to assess this patient is the myocardium is viable. So if we can expect some remodeling, if we should do something in the acute state. In the follow-up, I do not see with these tools available in our days many places to really give the patient a good option. So now the switch from the small vessels to the greater vessels, much easier to talk there because it's less hypothetic, it's more real. We have seen some of these images. It's now about the assessment of pulmonary stenosis or perfusion. And we can, of course, assume that there, while he is sitting the order, that the blood does not really like to pass through these thin vessel segments, that there might be some deterioration. But even if the vessels are not thin or, let's say, stenotic, we have funny situations like this, for example, where we have a pretty steep angulation of the right pulmonary artery and a not so steep angulation of the left pulmonary artery related to the main pulmonary stem. And now look at these 4D. It's also maybe a tool for boys, but because we have now only a pretty image, but maybe let's talk about that later, also some helpful information. You see that there's a clear perfusion mismatch. The blood aims to go straight into the left pulmonary artery and does not really like to go to the right. We have here some spots of turbulences also. And now, if we have a perfusion mismatch, again, it was said the indication would be 25%. When we have a perfusion mismatch of 25%, then we should do something. I'm not even talking about a pressure gradient now, only about a perfusion mismatch. Let's say we have a 40%. What can we do with this patient? Probably there's not too many things we can offer this patient in terms of treatment, how to improve the situation. And the goal should be not only to think about these, could we maybe improve and stand and or not. Basically with our methods available here and applying some computational fluid dynamics, we can calculate also probably in the near future how the outcome will be if we might place a stent in such a patient. Of course, here we would not consider that, but only theoretically, so that we feed our computer with the data about anatomy, about flow, and he spits out a recommendation because he can foresee the outcome of such an intervention. So how should it look normally, blood flow in the pulmonary artery? It's pretty much straight aligned. So we are talking about near laminar flow. We know never have laminar flow situations in the human, but near laminar flow. So this would be laminar flow, everything nicely lined and in circles and very clear. In the aorta, it looks different. You know this things from your sink this morning. It's a swirl if you leave the water go, and it's left turning swirl. And we have the same in the aorta. We have left helical flow in the aorta, in the ascending aorta. And we have to have that because the blood flow must go through the aortic arch. And it would not be helical, then we would have severe shear stress effects at the arch. Basically, we would have very low pressures, under pressure at the smaller circle, and this would then damage the endothelium and so on and so on. Well, I don't know how this is looking down under. I have heard that that the water is circling right in Australia. Is that true? So we need data probably also from people from New Zealand and see if it's also there, left helical, but I don't know. Might be an interesting study. What I can tell you though is that it's in our TGA patients, and I'm talking about the CCTGA and master patient. It's not like that. Look yourself at these images. Is anybody appreciating here any helical flow? No, it's laminar. And look at the pulmonary artery, it's helical. So this is a patient, we scanned them in Europe. So there must be an explanation for that. And if we look at the myocardium, at the microstructure, these are MRI diffusion tensor imaging, you can dissect by this imaging method like the pathologist, but much better because we can do it 3D. The myocardium and see how the muscle fibers are orientated. And in the left ventricle, we have something which we call the Creel's Triebwerkzeug. So this is putting a lot of force on the ventricle for ejecting it is important. The right ventricle, we do not have that, and there has been published last year a very interesting paper actually from a group from Morten Smerup. He is a surgeon, he is doing imaging, yes, things like that exist. He is from Denmark, from Aarhus, and he showed that due to probably this lack of this Triebwerkzeug, the right ventricle is not able to adapt actually in terms of, and I'm only talking about in terms of architecture of the heart, to pressure overload. But this complex architecture, particularly for left, is doing also something which we know as twist. There are people believing that the heart is twisting, others said, no, this is nonsense. Whatever it's true, we know that there's a three-direction movement of the myocardium, and we know that the movement of the myocardial wall is different at the base compared to the apex. So there's a kind of twist, yes, and how important clinically it is. And this might be one of the reasons how these blood flow directing in the pulmonary arteries are, because if you look at this now, I hope it's starting, and you might have observed that yesterday evening. Short break.
Für alle, die das Wahre lieben. Das einzig wahre Warsteiner. Gewählt zum Produkt des Jahres Warsteiner Radler Zitrone. Und ganz neu und nur von Warsteiner Radler Grapefruit. 100% natürlich, erfrischend, fruchtig. Jetzt probieren.
Did you see what I mean? Maybe it's easier for those who are drinking wine, actually. Oh, one back. Because there one more effect is very interesting, now without sound. The blood comes in, it turns, it makes a clear movement. Now the ventricle is filled with blood. I'm still pouring something in. No movement anymore. Yeah, it just sits there. And this is a pretty easy way how actually to visualize how the blood kinetics in the ventricle must work, because we do not only want that the blood goes from the left atrium and fills somehow the ventricle. No, we want that the blood comes from the left atrium or right atrium into the ventricle and does not lose its kinetic energy. And if you look at the patient now, it looks like that. So passing from the AV valve, we have here these kinetic moments. We can clearly see kinetic moments. The blood goes in and is then going out, like filling a glass of beer or wine. Now, if the ventricle is filled, it's dilated, we are losing definitely this kinetic energy. So we have to talk about the interplay between myocardial function, dilation of the ventricle, but we have also, and we see that now in a very interesting study we just initiated actually with Dr. Zeniavsky, that in different forms of mitral valve dysfunction, we have different forms of kinetic energy within the ventricle. So the diseased valve is directing the blood different to another diseased valve. And probably this has also something to do with how the blood then finally is arriving the pulmonary artery and the aorta. So it's the geometry, it's the loss of kinetic or the redirection of kinetic energy, and of course it's also the loss of twist, which is causing that. And we have to keep that in mind, that we do not only look at the myocardium itself, if we are talking about myocardial performance, contractility, but we have definitely also to see the geometry, and we have to see the size of the ventricles, the ventricular dilation. And there, this is still unpublished, the data, but it's under review. This is from fellow patients. This data, more than 500 fellow patients from the Competence Network, the German one. We see, or we suspect, actually, we stated, the reviewers, they hopefully state the same thing, that there's a gender differences between males and females. So the females, if we are looking now here at the right ventricular systolic volumes, we see, and we are talking about the standard deviation score range. So this is the deviation, how many of the patients are deviating, how much from the normal range. We see, well, bigger 8. Is it 8? Yes, it is something like an 8. We see much more females having stronger deviations than the males do have. So they seem to develop much earlier, actually, ventricular dysfunction, right ventricular dysfunction. So I want to close now the talk with some final remarks about complex TGA. We discussed that yesterday back and forward, aortic root translocation and so on. Obviously, I don't do that. And we talked about also the imaging modalities which are in place for doing that, echo, angiography, MRI, and we showed actually this image already 2 years, and I know that from somebody, he said 75% of the audience here are coming back every year. So 75% should know what this is. Does anybody remember? What was that?
Footprints in the snow.
Footprints in the snow, okay. An elephant. A Snoopy?
No.
Oh, you're fantastic. This is a good example how somebody is able to translate 2D into 3D. And it's always, and it's always fun to have the surgical discussions with our surgical colleagues, and it's interesting visions the one has, the other one, and sometimes complicated to share the vision. So I think 3D definitely is more than just a tool. It became more than just a tool in the assessment of the complex things. I'm not going into detail now here, but this is a 3D visualization, intracardiac. This is septum, right ventricle, left ventricular outflow, and we can see the blood pool pre-operative and post-operative. Okay, this is good for diagnostic, and actually I like diagnostic if it's standardized, if it's not observer dependent. I mean, just imagine Mr. Chowi looks out of the window in January, rain, grays, getting depressive, and is saying, okay, I'm leaving Berlin, and then we do not have such high quality prenatal imaging anymore because it's so highly observer dependent. But I think another thing is also important, not only to overcome the limitation of observer independency, but I think we're having the foot in the door to go even one step further. And this is to, by means of computer, to plan actually the different treatment options before we actually operate. So the step one would be a high quality imaging, 3D visualization. Step two, to compute in this model the surgical options which we're having. This would be the conduit. Might it function? Is there a V-valve affection or not? And then hopefully have great results. So in my opinion, we will see in the next few years a change from an imaging from a purely diagnostic modality into one modality which is then actively supporting, assisting surgery intervention and even predicting outcome. And to reach this goal, I'm very proud to have also these fantastic group here in Berlin with all these fantastic ideas. Thank you.